Thank you very much, Kevin. And I would like to welcome as well Dr. Regina McQuillan to take a seat here, Austin McCracken as well to take a seat, and also Emer O'Flynn to take a seat, because this is a joint presentation between the four of us. So thank you. So we're absolutely delighted, and if any of you haven't picked one up as you came in, we're launching the All Ireland Research Priorities 2025 to 2030. There are 24 priorities, and these kind people are going to go through them with you. So why are we here? You know, we know that palliative care affects everyone. It is an ethical responsibility by the World Health Assembly. There is a growing need across the island of Ireland, both in the Republic of Ireland and in Northern Ireland, and a lot of you are very familiar with that growing demand. And in the Republic of Ireland last year, with the publication of the National Adult Palliative Care Policy, there will be a move to further integrated care, and that requires an evidence-based approach. In Northern Ireland, the Palliative Care and Partnership Programme and priorities also stress the critical importance of research evidence to design and improve care. So research is a pivotal area that is required to support the policymakers and the service providers in this area. And unfortunately, palliative care research is an underfunded research area, not only across the island of Ireland, but across the UK, across Europe and globally. It is an area that could really benefit other healthcare areas. We're delighted to have two key funders here today, the Health Research Board and the Public Health Agency, HSE R&D, who have supported the infrastructure support, as Karen mentioned, for the PCRN. But it is a real opportunity to invest in research in the palliative care area. So how were these research questions, as I mentioned, how did these come about? So the Institute was asked to become part of a UK-wide and include the Republic of Ireland James Lind Alliance Priority Setting Partnership Project. Sounds like a big mouthful, but the James Lind Alliance are an external facilitator that involve people with lived experience and professionals to help identify priorities. So they have a poll process. We have a report on this, so you can read that at your ease. It included a survey of patients, carers and health and social care professionals across the UK and including Northern Ireland, and then also including the Republic of Ireland. And then we had a final All-Ireland prioritisation workshop, and Regina, Emma and Austin were all involved in that. And there are other people here today who were involved either as participants or observers. So we're building on our previous work in this area, because some of you will say, well, we already have priorities, but they were developed back in 2015. A lot has happened since then. We've had COVID, we've had a change, and an evidence review was done to see, well, are some of these priorities still valuable? Are they still needed? And yes, a lot of them were, but there was considered that it needed to be a refresh and an update. So the project had a number of steps. There was a steering group that I was glad to be involved in with other key members across the UK and including in Republic of Ireland. There was also a lived experience group that very much impacted the project from the very start. There was a survey then sent out across the UK, including the Republic of Ireland, to healthcare professionals and people with lived experience of palliative care. From them, a long list of questions was created, and they were all systematic review and evidence checked to see if these answerable, have they been answered previously, and should they be brought forward. And then they were brought forward to a second survey that was again sent out across the UK, including the Republic of Ireland as well. And in the UK, they had to prioritise a setting workshop in November 2024, and they launched their priorities after that in February. And then we had ours not so long ago in October 2025. So for survey 1, there was 1,032 responses, 13.2% from the island of Ireland. This identified, as I said, 79 questions, and they were sent out in survey 2 for people to rank. And from that ranking then, 24 questions were brought forward for the UK one of the island of Ireland, and they were slightly different. They were mainly the same, but there was a few differences, and you'll see in the report. So who participated in the survey? I mentioned health and social care professionals, the public, volunteers, bereaved family members, carers, and people living with a serious life-limiting illness. And this is a lovely photo of everybody on the day. So we have all the people who were there. These were people who either observed, and we had somebody from the Health Research Board and the Public Health Agency, HSE R&D, and from the Department of Health were there, as well as the Institute members. And then we had 22 participants on the day, and they were an equal mix of health and social care professionals across disciplines, across the island of Ireland. And we also then had people with advanced cancer, heart failure, bereaved carer relatives, interested citizens, and they came up with the other 11. So we had 22 in total. And as you can see, there was a lot of group work and discussions facilitated by 3 James Lind Alliance facilitators to come out with the ranking of the top 24 priorities. So, and here we have when the final discussion and final group saying which the different priorities were. And just to say, we got feedback from the James Lind Alliance to say that there was very good discussions in the small group, and there was great consensus and agreement in everybody listening to each other and coming together to identify those priorities. So with that, I'm just going to hand over now to Regina McQuillan, who will take you through the top 10. Thank you, Regina.
Mary said to say a little bit about myself. So I'm a palliative medicine consultant. I work at St. Francis Hospice and Beaumont Hospital. And I suppose obviously my role in research is more about facilitating rather than doing research, because I think that maybe just reflects my clinical workload and things like that. But it is something I think we need to be continuing to do and develop. I think it's interesting being here in the Wood Quay venue, because this was a great site of research, and some of us like myself are old enough to remember when this excavation was being done. And then there was High Court actions and the excavation was stopped. And then there's High Court actions to get going again because of this sort of dispute of whether or not something should be built on the site. So just to let you know, you are currently on the second biggest Viking site in the world. So Dublin was second at the time to Vladivostok. So this is what we have of the second biggest Viking site in the world. Nice wall with numbers. So, if we're looking there at the prioritisation, and I suppose the first priority is actually very broad, and in some ways you might say the first one covers practically everything, because it is, what are the best ways to provide personalised palliative end-of-life care that meets the physical, mental, practical, social and spiritual needs of a person with a serious life-limiting illness? And that basically covers, I say, everything. But at the same time, there can be, and I think I suppose it's a big ambition, but I think then that big ambition, that's where we're aiming towards. What we want to do is provide the best care for people. But then that comes into other points then after that maybe help, other research priorities will help that. Oh, apologies. So the second one then is about how can communication and care coordination be improved. And I think it's very important, how can that be improved for people with serious life-limiting illness, from diagnosis to end of life. And although there's been some work done in some areas, maybe particularly in cancer, it's not as well done in other areas and has been referenced already. There's more move towards having more integrated care, more care delivered in the community. So how do you ensure that we have better and engaged in communication and coordination? Research priority number 3 is about the best way to provide emotional and psychological support for people with a serious life-limiting illness, because there are different models around, there are different things which are available, and how do you actually provide the right type of support? And whether this is a case that some people, what they need is the listening ear, and some people might need much more complex support. So how do you provide the right support and how do you do the right matching? really important thing to do, area of research, is what do you need to do to try and help people who want to die at home? What do you need to do to enable them to die at home? What skills do staff need, and what helps and hinders people from being able to be cared for and die at home? Research priority number 5 is about access. And how can you ensure that people have access to palliative and end-of-life care that they want or need? I think it's really important to that thing as well about wanting and needing, because for many people what they might need is, access to the palliative care approach in general palliative care. Some people might need specialist palliative care. So how do you ensure people have the right access and the right type of care, but also timely access? Priority number 6 is about providing support to children. So how do you provide psychological and social support to children when somebody important to them is dying or has died? So what sort of support does the child need, and probably what sort of support do the family need to provide support to that child? Next question then is in relation to staff training and education. What is the best way to provide staff training and support to people who are providing care for people, either at home or in hospitals or in nursing homes? Because education is provided, but how do you know this is the right type of education, and what is the right type of education, and how can you improve the education to provide better care for people? Next, research priority number 8 is about caring for people with illnesses other than cancer. So although now we would, in all specialist palliative care services, care for people with illness other than cancer, my own service about 40%, but I think it is that cancer still may be the dominant thought and idea when people think about palliative care and end-of-life care. So what is the best support for people with illnesses other than cancer? And again, that might also include how do you improve things such as the general palliative care skills of people providing care for situations, for people with things like chronic illness such as COPD. The next point, number 9, is how can you improve the quality of palliative and end-of-life care in hospitals? It's only 40% of the population will die in an acute hospital. So although in acute hospitals are actually designed, die in hospital, maybe not all acute hospitals, but although hospitals are designed to treat and save lives, at the same time that's where a lot of people die. So how do you improve palliative and end-of-life care for people who are going to be dying in hospitals? And then the last point I want to raise or talk about, number 10, before I hand over to my colleagues, is then how do you support family, friends, family, informal carers? How do you help them support the person who's dying at home? What sort of information do they need? What sort of training do they need? What's the best way of helping them look after somebody at home? And are there advantages to this or disadvantages to this? And that is something that will come up like in one of the workshops. Like if you're providing a lot of training to family members to provide care, will that mean that the family members will be concerned they'll become sort of semi-professional caregivers and will no longer have the family role, or to be less semi-professional caregivers? But those are the type of things that we need to look at. Is how can you help family members, in the broader sense of family members, their friends, your carers, and your friends' network. How do you help them support somebody who is living at home and wants to die at home? And what type of support family members might need? And whether that's giving medication, helping people move or turn the bed. How do you train people to sort of maybe change bed linen when somebody's in the bed? What are the sort of things that are needed? And how is the best way of providing that? And is it overall a good idea, or are there challenges or harms associated with it? So that's the top 10. I'd said to Mary we were doing the top 10 from 1 to 10 rather than reverse order, because everyone's going to get them on paper anyway. You're going to see them, so doing the reverse order, there wouldn't have been a surprise anyway, because you have the paperwork. I'm now going to hand over now to Austin. So Austin is going to do the next lot of the priorities. Thank you very much.
Well, good morning, everyone. What are your expectations today? Nervous? Excited? Let me tell you that nervousness is excitement when you're expecting a negative outcome. But excitement is nervousness when you're expecting a positive outcome. Let us be positive. Let us be excited in relation to what's going to happen today. Let me give you a little introduction to my coming to this workshop 5 weeks ago. On the bus I was excited when I passed the Dublin City Council offices. What did I see? Well, sitting outside the Dublin City Council offices. Come on.
A sculpture.
Flags.
Something else much more important than flag.
Sculpture.
Sorry?
A sculpture.
A piece of sculpture by Michael Warren. 40 years ago I met Michael Warren in the studio in Goria. and it was designed by Scott Talon and Co. And I've been in contact ever since. Let me bring you to 4 months ago, whenever I visited his home, a couple of days before he passed away. And that family had the highest regard and comments for the palliative care that his wife, his mother, his father, speaking to his son, that his son received, that the father received during his illness. Ladies and gentlemen, I want you to be more aware of your environment, not from a commercial point of view, but from the other person's interests. And that's why we're here today. I have 3 little comments before I comment on my 11 to 17 questions. Whenever I was faced with these 24 questions, I found it very challenging. But ladies and gentlemen, I'm for the challenge. As an art dealer, I'm always interested in integrity, in provenance, in double checking. I have a mantra. People don't necessarily do what you expect, but they're certainly going to make an attempt what you inspect. And I want to assure you, ladies and gentlemen, that I will be inspecting the results of this conference today. It'll just not come and go and nothing happen, as so often happens, by the way, when we come to conferences. There's no follow-up. I was challenged. And going through the 14, I had to spend a few weeks monitoring and thinking about them and wondering what did I want as a priority in these research projects. Not only that, I was challenged because I had to come to a conclusion. I couldn't sit on the fence and let other people make the decisions. I had to have my opinion. And listen, ladies and gentlemen, we must respect other people's opinions. And Mary Rabbit has already referred to it, Professor Rabbit has already referred to it in that there was a fantastic consensus. We all agreed with the #1 project, and what excited me was that it encompassed every facet of medical care. The physical, the mental, and very often neglected, the spiritual. So as I come to the 11 to 14 to 17, I want to highlight number 13. I would consider myself fairly specialist in that area, having spent 14 years caring for my wife, who had Alzheimer's. It was a joy. It was a privilege as her husband, but it was also a challenge. It wasn't always easy, but as I look back, I have absolutely no regrets. Why? Because I gave it 100%. Listen, ladies and gentlemen, when you give your attention to something 100%, you live with no regrets. If only I had it. If only. That doesn't come into the equation. No regrets. Caring for her. But there was another important element which I discovered, which is equally important in every situation. You and I, as carers, we must put on the oxygen mask. Have you ever gone to the airplane? Before the airplane starts off, they give you warnings about, in the event of this happening, put on an oxygen mask, because you can't help the person beside you unless you have the oxygen. Unless you're reading 96, whatever it is, if you go down to 90, you don't have much energy. I can assure you of that. Get on the oxygen mask. How did I put on the oxygen mask? Let me give you an illustration. My wife's day was from 10:30 in the morning to 10:30 at night. 7:30 in the morning I was up. And in Donegal, you were able to, you bought a Daily Telegraph, you were able to get a cup of coffee. I got a cup of coffee, Daily Telegraph at 7:30, took the shoes and socks off, and went into the tide. And had an hour walking along the edge of the water, clearing my head. And whenever I went back at 10:30, I was ready for whatever was coming. I was ready. Why? Because I had the oxygen mask on. Ladies and gentlemen, Alzheimer's for me was very pleasant. But I go down to the next one. Number 15. My mother lived to 98 on her own, in a house on her own for 25 years. Never in a nursing home, never a urinary tract, never a bed sore. Why? Because rarely did I pass that house without calling. 12 o'clock at night, I would have opened the door, and very often I would have heard her singing. If I didn't hear her singing, I slipped up to the bedroom, and as long as I saw her breathing, I was happy. Went back out and closed the door. We must learn to care. That's 110. We must give it 110%. And so she lived to 98, and again, living with no regrets. Listen, gentlemen and ladies and gentlemen, I must close. We must give you something to think about. And it's what Mahatma Gandhi said, we must become the change we seek. It starts with me. It doesn't start with a hospice. It doesn't start with a nurse. It starts with me. We must become the change we seek. And one final comment. When Paul talked to people in Philippi, he said to them, it's God who works in you to will and to act according to his good purpose. One of the great lessons I've learned in life was the greatest work that my Creator has to do with me is change me. May he change us all for the right purpose we've been set out for.
Hi, good morning everybody. How fun of that, eh? So my name is Eva, and it was a pleasure when Mary called me to ask me to participate in the workshop. I haven't actually participated in a workshop like that before, at all. But I came to it, I suppose, with two hats on. Predominantly, I think initially Mary had invited me to participate on the back of the fact that I'm actually working with a number of other advanced cancer patients. I'm a metastatic breast cancer patient myself, and there's a number of us working and collaborating with groups like the AIIHPC and others to try and raise awareness around the needs of advanced cancer patients, because while the primary cancer care area is very, very well serviced, it begins to unravel when you get into the secondary space. And one of the fascinating things that was born out of research was that a lot of people with advanced disease, they really want access to palliative care early, not for end-of-life care, but actually for quality of life care and for symptom control care, for symptom control care. And that's really around extending the ability to enjoy life, but also to improve the efficacy and the extension, to extend the period in which primary treatments and subsequent treatments can actually be effective. So I came with that hat on, but I also came with a second hat into the room, which I realised at the time was actually also quite relevant, in that my husband, in his latter days of life, and latter weeks of life indeed, was cared for in St. Francis Hospice here in Dublin. He had motor neuron disease, and so I saw directly end-of-life care as a carer and as a spouse of somebody who was dying in front of us. So I've seen both the power of end-of-life care, and I know from my colleagues the importance of symptom control care and quality of life care. So for me, palliative care, and that's something we probably need to educate people on, that it's not just about end-of-life. But there we go. So that's my context. So if I may, I will share, go the right way here, the final 7. And I would have to say at the outset, these final 7 are not the weak 7. There was no weak topic discussed in those rooms. Okay, the 24 on the shortlist, every single one of those is worthy. And if we had unlimited resources, you'd do all of them, in whatever order. But faced with a situation where we have finite resources and have to make choices, I must admit I was fascinated by the James Lind Alliance process, because in a group of 22, I think you said, Mary, very diverse people. I see many faces in the room here today who are there, from students, through carers, through patients, through clinicians, through psychologists, through community care specialists. Isn't it amazing that 22 people working in 3 different groups came to such a solid response, a solid outcome? And it was without bias, without groupthink. Everybody had an opportunity to say their piece, to give their perspective. And I think everybody walked away from the process feeling that their voice had been heard, that their contribution had been valued. And I really feel, I don't know if Regina and Austin would agree with me, I really feel like everybody went away feeling like, yeah, the 1 to 24, couldn't have done that myself, but that 1 to 24 is the right 1 to 24. So let me share 18 to 24. Equally worthy, but not top of the list for applying resources straight away. And I'll explain a little bit as to why that might be the case for some of them. So we look at number 18. How can health, social services and charities work more collaboratively to provide joined-up care that better meets the needs of people suffering life-limiting illnesses and their friends and their families? Very worthy. But that's all about operational delivery. And the sense in certainly the room that I was in was, if we tackle some of the other things first, that then defines what needs to be delivered. And then this one comes later, which is around then how do we deliver it, where do we deliver it? Is it in the community? Is it in hospices? Is it in a hospital setting? So it's not that this isn't important, it's just that some of the other ones come ahead of it. Number 19, about how do we ensure the best ways to ensure adequate pain relief for people with serious life-limiting illness. It was felt this is already pretty well studied, and those of you who are clinicians and practitioners in the space would actually be very on top of this one. So we felt that this is, yes, worthy, but there's a lot of evidential information already in that space.
Similarly, around what stops people wishes from being acted upon. One of the things we're fantastic about in Ireland is actually talking about death after somebody has passed. We're a disaster talking about the preparatory work beforehand. We do need to do work on that, but perhaps that's not in the palliative space. Perhaps that's more in the psychosocial space. And then if we look at teenagers moving into the adults, there was very strong recognition that, yes, that transition is very difficult to go from the paediatric system into the adult system. An important factor, but again, some of the other topics earlier mentioned would actually cover some of that logically. And then things that are specialised around managing delirium, managing dementia, managing end-of-life symptoms and clues, signals, if you like. We felt, again, there is some work already done in that space, so perhaps other topics need to be studied in more depth first. And then finally, the discharge from hospital. Again, if some of the other earlier topics were actually covered well, then that would be actually dealt with as well. So that was the totality of it, and as I say, a very, very useful experience, and I think a very robust outcome.
And finally, I'd just like to thank very much Emer, Austin, Regina, and everybody who took part, either in the surveys, because I know some people took part in the surveys, and especially those that took part in the workshop. And I'd just like to say, we've the QR code there. We have, as I said, the priorities here, with the final report, if you'd like to look at it and reflect on it. As an institute, we're always trying to promote things. We're going to use these priorities. They're not going to sit on a shelf. So we're going to encourage the key stakeholders that we work with, both the funders, the researchers, the service providers, the policymakers, and to focus on these priorities, because these are the priorities, as we said, have been identified by people with lived experience of palliative care and also professional experience. So just like to thank everybody for your attention, and if you haven't picked up one of these, they're just on the desk there. Many thanks.